I've learned over my career, if you let ADHD go untreated, even at a young age, especially at a young age, personality development is affected. You have a can't-do kid instead of a can-do kid. You have a kid with a negative self-image instead of positive self-image. You have a kid who's been getting negative feedback, redirection through early developmental years, rather than a child who is experiencing joy and pleasure and success in social communication and social connection.
Hi, good evening, everyone. I'm Moon Lake Lee, founder and executive director of Unlocking ADHD. Thank you very much for spending your Monday evening with us. We're really excited to be able to launch the first of our 2024 programs this evening, which is really to understand and manage the use of ADHD medication. Tonight's event will feature Dr. Dan Shapiro and Dr. Adrian Lowe. We just want to acknowledge as well the event sponsor that's made this webinar possible to be free for everyone, and that's our event sponsor, Specialist Dental Group. So we're really grateful to them, and we hope that for those of you who are listening, if your companies would like to do some CSR and support us so that we can continue to do such life-transforming work and make access open to all, please contact us. We would love to get more sponsors for our upcoming events this year. I just want to also share briefly about Unlocking ADHD. For those of you who are not as familiar with us, we are 2 years old. We are a registered charity and social service agency, and our mission is to empower ADHDers and their families to live life to the fullest. And we are trying to address the problem that the symptoms of ADHD cause impaired relationships and cause underperformance in school, in work, and life, leading to lost potential. So we're using awareness, accessibility, achievement, and advocacy as our 4 pillars to address the issues on the ground. As a young charity, we're in need of a lot of support. So if you find the information helpful today and all the other activities that we're doing, please make a donation. You can scan the QR code in front of you. The donation is to the Give.Asia website, and we are tote bot eligible. So basically, your donation has more impact that way because it is multiplied. The other ways that you can support us is to sponsor our programs, as I mentioned this year, so that we can make them more available. And also invite us to your companies to share about ADHD, diversity, equity, and inclusion. We do have a lot of experience as ADHDers ourselves about living, surviving, and managing in the workplace. If you do have a corporate fundraising event, do consider us as a beneficiary. Or if you'd like to do a special fundraising project on your own, please do consider us too. And for those companies who are looking for a charity to adopt, please do consider Unlocking ADHD. I would like to introduce our speaker for tonight. Dan Shapiro is very special to us. When Unlocking ADHD was launched on October 1st, 2021, Dan was actually the very special person who launched Unlocking ADHD with a talk on whether to medicate or not medicate your child with ADHD. Dan has been a wonderful supporter. He's a developmental behavioral pediatrician in the US, and that's a very specialized area where they work particularly with children with multiple conditions, whether it's ADHD, anxiety, ASD, autism spectrum disorder. And besides being a pediatrician, Dan also has a heart to do parent training. So Dan has a wonderful program called Parent-Child Journey, based on his books of that title. And I've personally benefited a lot from Dan's work in this area, and that's why we partner with Dan. And Dan's programs are basically a pay-what-you-can basis, which is why I love them so much. So for today, Dan's with us to share about ADHD medications. He has worked with us before as well to do workshops for parents with youth and young adults. We're hoping to do more in the future. Dan has written 3 books, very, very seminal. I will highly recommend it. He's a fellow of the Academy of Pediatrics and also the Society of Developmental and Behavioral Pediatrics. So without further ado, please help me welcome Dr. Dan Shapiro. Thank you, Dan, for being with us. It's very early for you. Nice to see you again.
Thank you, Moonlake. I really appreciate the invitation here and love working with you and your wonderful, wonderful organization, Unlocking ADHD. So I'm real proud to have my name alongside Unlocking ADHD and you. So thank you. So I'm going to be covering a lot of material here and trying to do it efficiently. and we'll buzz through some basic concepts together. And I hope that this is helpful to you all. So in part one this evening, we're going to very quickly review not the basics about what ADHD is. I'm sure you're all familiar with that, but a few more nuanced concepts, and make a strong case for treating ADHD with medication as part of a comprehensive treatment plan. Medication's never the whole answer, but it is a foundational piece, a cornerstone piece to effective treatment. And then I really want to spend most of the time talking about a systematic approach to ADHD, science of prescribing beyond art, and how to do a medication trial. And then next week, when we regroup, we're going to talk about troubleshooting, side effects when coverage isn't even through the whole day, reasons for discontinuing medication, and glad to cover some educational, behavioral, psychological supports. But the primary focus of these two workshops is going to be medication management. So thanks, Moon, for mentioning my books. There's a QR code here and a link there for other courses that I offer. So I want to just start out with some general concepts that remember, most inattention is not ADHD. Really, the whole textbook of behavioral and developmental pediatrics can result in difficulty with inattention. So there is such a thing as non-impairing distractibility, impulsivity, and hyperactivity. We call this normal human variation. Only if there is significant impairment across time, across settings, across people, do we diagnose a disorder. You can have environmental factors compromising attention in the classroom, with play situations, home situations. You can have insufficiently engaging tasks, especially for the gifted, distractible child, but also for the kids with average or below average cognitive abilities when the tasks are not adequately customized for the individual's cognitive profile. Remember that the whole range of mood disorders, anxiety, depression, mood dysregulation, bipolar illness, often, usually compromises attention. Trauma, stress, learning disabilities. There is something that was called sluggish cognitive tempo, and then concentration deficit disorder, and more recently called cognitive disengagement syndrome. This is a subtype of inattention, different from classic ADHD in that the gears turn more slowly. Medication can help, but less reliably for these kids. I'm glad to field questions about this fascinating subtype of attention disorder. And then any fine motor, gross motor deficits, if you're being asked to perform in these areas of weakness, you can have your attention wander. Sleep problems, medication problems, medical problems, social difficulties, sensory differences, you name it. Inattention can be secondary, not a primary problem with ADHD. But most ADHD is not just ADHD. When you have ADHD, you often have coexisting conditions. Anything on this list, at least 2/3 of children and adults with ADHD have some sort of coexisting condition. So we want to get away from this either or thinking. Is it ADHD or anxiety? Is it ADHD or learning disability? Is it ADHD or autism, or, et cetera, et cetera? Often ADHD is an and. It's ADHD and these other coexisting conditions. And often when you have a little this, a little this, a little this, anything on this list, if you look at each problem separately, you might say, not a big deal, not a big deal, not a big deal. But when you combine them, there can be, as Mel Levine used to say, dysfunction at the junction of the functions, which is just a cute way to say, hey, when you combine a little this, a little this, a little this, if in isolation they weren't impairing, in combination, there can be significant difficulty. So we want to have this and thinking about the child's whole profile, not just focus on the ADHD or any of these other potentially coexisting or underlying conditions. So diagnostic complexity is the theme. Dr. Barkley, who is our leading guru in ADHD research, anything he writes is golden as far as I'm concerned. would like ADHD redefined. ADHD can be a misleading diagnostic term. He would prefer, and I agree, that we call it a disorder of executive function and self-regulation. That is more comprehensive label, and this is important because a diagnostic and statistical manual checklist kind of criteria for a diagnosis of ADHD are often based on childhood symptoms, the hyperactivity and impulsivity being emphasized. But as you get older, hyperactivity and impulsivity usually soften, and you're left with the more subtle executive dysfunction issues, how you talk yourself through things, how you motivate yourself, manage time, organize, and mood regulation. These important pieces to ADHD, especially as you get older, are often not included in checklists designed to diagnose ADHD in childhood. So you might outgrow pediatric criteria as you get into adolescence and adult life, not lose the diagnosis, just have ADHD presenting in a more subtle, sometimes more difficult to diagnose way. So we want to get away from standardized office-based testing and DSM symptom checklists, which look for more obvious ADHD symptoms, and get to more subtle, real life manifestations of the disorder. And so that's why parent and teacher ratings of executive function in real life daily activities are generally more valid than sitting a child at a desk and having them perform tasks out of the context of their real life. So I want to emphasize this point, and we're going to quickly get to how to treat ADHD. But ADHD is not just about performance enhancement. It's not about getting your child into the best college. It's not about helping a child get good grades in school. It's a life issue. So if you don't treat ADHD, a disorder of significant impairment, there are real consequences. Mood disorders, anxiety, depression, even suicide, 30 to 50% increased risk for everything on this list if you don't treat the ADHD. Family stress, marital problems, divorce, substance abuse is increased if you don't treat ADHD. These medications lower the risk of substance abuse. They don't increase the risk. Interpersonal problems, social failure, risk-taking behaviors, motor vehicle accidents, school underperformance, failure to attend or complete college, unemployment, homelessness, juvenile delinquency, problems with the law in adult life, and you can have a shorter lifespan if your ADHD is not treated because you don't take very good care of yourself. So it's a big deal. It's a public health crisis if we don't diagnose and treat ADHD adequately. Now, I'm going to put up a controversial, strong slide here. Oh, maybe not. But Dr. Barkley has said that it's malpractice to not treat ADHD when medications are so effective. We've got these severe consequences of failure to treat. So again, we're not talking cosmetic psychopharmacology here. We're talking about treating a real disorder. Now, when we do a medication trial, let's get to the nitty-gritty here. We're going to choose targets and medications and be objective about response to medication and monitoring for side effects. So this is how I do it. And you can click on this link and go to my website, scroll down on the resources page and hit the stimulants medication trial link. And these blanks will be filled in. I deliberately leave it blank because, again, the targets for childhood will be different than the target symptoms for teens and adults. But for childhood, distractibility, hyperactivity, impulsivity, school problems, social problems, etc. And we'd ask parents to say at baseline, when there's no medication on board, is it no problem, little problem, medium problem, or big problem? All the way down what would be a longer list on the target symptom upper half of the page, and then the possible side effects that you're all familiar with: appetite suppression, irritability, insomnia, tics, etc. would be listed here, and we do baseline ratings, 0, 1, 2, or 3, for possible side effects before we start a medication trial. Just because they're possible side effects does not mean that they're going to happen. In fact, most side effects could get better with treatment. For example, you can eat better on stimulant medication if you sit at the table long enough to enjoy your meal, or you could eat worse. Because it could be worse, we monitor, and we have baseline, and we're going to be comparing baseline ratings for both target symptoms and possible side effects as we gradually introduce medicine and increase the dose. The idea here, 2s and 3s, medium problems, big problems, we want those 2s and 3s to come down to 0s and 1s. That means remission. That means complete treatment of ADHD so that you would seem like you've lost the diagnosis, even though you haven't. You can have a partial response, though. 2s and 3s could become 1s and 2s. We want to go for those 0s and 1s if we can. But if possible side effects start to creep up as we increase the dose, we may not be able to get to complete remission. We may have to settle for partial response. But the idea is to gradually increase the dose, having parents, teachers, and for kids who are old enough, they should participate in their own treatment trial and learn about their ADHD by completing this form or modification of it. We're going to modify what we do with the dose, increase if there's no change. If the 2s and 3s all come down to 0s and 1s and there are no significant side effects, then we're going to stay with that dose, looking good. If nothing happens, the target symptoms and the possible side effects are really not impacted, then we're going to increase. If we get into side effects before benefits, we're going to bag it. If we have side effects and benefits at the same dose, then we can perhaps decrease the dose a little, lose the side effects, keep the benefits, or we might have to go back to the drawing board. If you get into side effects before benefits with one stimulant medication, then you should try at least a second and perhaps a third. If you can't tolerate stimulant medication, our most effective meds, then you might go to non-stimulants. So we do have all of these stimulant medications, methylphenidates, dextroamphetamines, and in the United States, dexmethylphenidate, not available in Singapore. But you should try at least one medicine from each of the stimulant families. If those don't work, non-stimulants are available. If you get partial treatment with a stimulant, you can supplement by adding on a non-stimulant and do combination of stimulant and non-stimulant. Generally, we go with long-acting medicine because it's easier to take a medicine once a day that lasts through the day than taking medicine several times a day. But short-acting medication can be used, as we'll talk about next week, to extend duration of coverage. And the choice of medication really depends on, you ask the child, or the parents know the child, hey, what will your child be able to take? Some are not pill swallowers, but we've got all of these options. We can crush, chew, sprinkle capsules, dissolve powders into liquids. We can have liquid suspension medications. There are patches that can go on the skin. And in the US, insurance coverage affordability is a big deal, not as much of a factor in Singapore, I understand, but I need to mention that for the few Americans who are up at this hour and might be attending this conference too. So talking with the child is very, very important from the very beginning. And we want to avoid stigma. Hey, everybody's got something. You've got ADHD, but we can help. And we're going to be realistic about, hey, this might work, might not. We're going to give it a try. Call the medicine what it is. They stop and think medicine, an ADHD medicine. Don't call it a vitamin. Don't hide it. Be open and honest and transparent with your child, even at very, very young ages. It's hard to unexplain things years later if you haven't been straight with your child from the very beginning. So we can call it stop and think medicine, focus medicine. We can use similes, metaphors like, hey, the brakes on the bike are not working as consistently as we'd like. Great bike, brakes are a little bit inconsistent. The conductor in the orchestra might be asleep. The airplane pilot might need a little bit of a poke to stay awake. And how does the child describe their own problems is often a good starting point. We want to avoid negative language, self-deprecating language like stupid, my brain doesn't work. Stay away from that kind of negative messaging, please. And we want to normalize that, hey, people take medicine for different things, ADHD, allergy, you name it, it's okay. And if there's media figures that the kids are into that have ADHD features, we can help them understand in that way. And some of my patients really like to understand neurophysiology. We do know how these medicines work, and we can explain prefrontal cortex function, dopamine, norepinephrine, reuptake inhibition, draw pictures. And for those scientifically oriented kids, maybe some of them will be taking my job, years down the road, becoming fascinated by neurophysiology in their own brains and hopefully applying that knowledge to others. So we want to follow the child's lead. There is such a thing as too much talking. There's such a thing as too little talking. We don't want to communicate too much of our own anxiety to our kids. Keep it as matter of fact as we possibly can. So this is an important consideration involving the child, educating the child from the very beginning. So if you want more detail about this topic, I've got a video you can find on my excursions page on my website. You can hit the QR code or this link. And this book, Parent-Child Excursions, the first chapter is all about the course content this week and next week, but there are additional chapters on coexisting anxiety, autism, and gender variation. The second book is about the parent training program. A new cycle, by the way, is beginning next week for those of you who are interested. So that is what I had to say by way of introduction and just some outlines. And I would love to field questions and involve our colleague there, Dr. Adrian Lowe, in the conversation as well. So Moon Lake, you want to take it from here?
Sure, I will. Thank you so much, Dan. I think you did an amazing job just to break it down to make it easier for us to understand. So thank you for that. And definitely the step-by-step on how to do a medication trial is very, very useful. I'd just like to quickly introduce Dr. Adrian Lowe. Adrian is a senior consultant psychiatrist at Promises Healthcare, and he sees children and youth with ADHD, I think increasing now adults as well. He was previously in the military for 2 decades and is continuing to serve academically as well as a consultant with the Institute of Mental Health. So Adrian, thank you for joining us today. And I'm excited because today is the first time that Unlocking ADHD is bringing expertise from the US and expertise from Singapore together. So we really make sure we have the best practices, but also localize it and contextualize it. So maybe we can start off with Adrian. Did you have any thoughts or responses to what Dan was sharing earlier?
Hi, good evening to all our participants, and thank you for taking your evening to join us. And I'm really, really honored to be part of this today's webinar. And then I really learned a lot from just listening to your presentation. So I just really feel really honored to be part of this. Yeah, so I think after listening to you, maybe I'll just share a few of my practices, local perspectives. So one of the points you mentioned that's important to get a good differential diagnosis. And I think that in the local Singapore context, one of the studies that's been done across the world is been shown that Singaporean students actually sleep one of the least in the world. Yeah, so when I do meet some of the students who come to see me in the clinical practice, I really try to understand how much sleep they get first, because I think it's quite clear when someone is not rested, it's going to be really hard for them to be attentive. And the problem is particularly bad in Singapore because the school starting hours in Singapore are pretty early. Typically, schools start at around 7:20 to 7:30 a.m. So many students are pretty sleep deprived, and then they stay up late to do their homework. So I try to get it out of the way first, as part of the conversation and evaluation. And I think with regard to the issue of stigma, I can't emphasize enough how till today there is still a lot of stigma regarding anything to do with mental health issues in Singapore, including ADHD. In Singapore, the local dialect, there's a lot of words in the local dialect uses the word key cell, which is a cell. Basically it's a term that means crazy or mad, or it's basically someone with psychiatric illness. So the older generation especially sometimes they can be particularly very resistant towards the use of medications. I've actually come across, and in Singapore, because a lot of families still very much stay with grandparents or meet the grandparents regularly, I've also come across instances where the parents desire to start the children on medications, but there may be other views in the rest of the family. So one of the features, I think, in the local clinical practice is to be able to engage multiple care, the parents as well as the grandparents, where they play a significant role in the upbringing of the child. One of the good and bad things in Singapore is that we don't have so much choice of medications. Yeah, so that makes it a bit easier for us. I think in the initial list that Dan showed me and the US references, it's really a staggering amount of choices for medications, just like going to a US supermarket and all the brands for different products. So in Singapore, we do have a slightly smaller array of medications, but nevertheless, most of the most effective medications are available locally. So that's something I just want to reassure our audience. Yeah, so I think those are some of my perspectives in response to Dan's sharing.
Thank you, Adrian. Really appreciate that. I thought maybe we'll just start off light first, okay? And we'll talk about what are the 3 most common misconceptions, when it comes to medication. Because we're finding that actually, people get information everywhere nowadays, from the internet, online, magazines, articles, relatives, and all that. And not everything, has evidence base. And it's solid. And that's one of the things for unlocking ADHD, that we want to work closely with the professionals. So we're making sure that the information that goes out there is accurate. So one of the common misconceptions actually that we've come across is that taking ADHD medication is addictive. Once you start, you cannot stop. So maybe Dan, maybe you can try answering that one first, and then before I pass it to Adrian.
Yeah, I refer people to the research done by Dr. Timothy Willens, Wilens, at Harvard. He's the head of the child psychiatry program there, who also runs the substance abuse clinic at Boston. His research shows that treatment of ADHD lowers the risk of substance abuse. ADHD medicines, if abused, could be addictive, but I've never, in my 40 plus years of practice, seen a case of addiction to stimulant medication. It's so rare, more an issue of psychological addiction than physical addiction. So it is abused on college campuses by students who want to pull an all-nighter studying. It's a performance enhancement drug. That's where it's abused, not to get high, not as a recreational drug. There's not dependence, but we do need to be careful about misdirection of prescribed ADHD medicine, especially on college campuses, where one pill of Adderall can fetch $50 on United States college campuses. Hey, I've got a big test tomorrow. Do you have some Adderall? So that's an issue. But addiction in real life is not a problem, in my experience, or according to the research. In fact, my problem with teenagers is to get them to take their medicine. They're not addicted to it all. They're often resistant to it. There's not craving. There's, throwing it in the trash. So yeah, treat ADHD if you want to lower the risk of addiction.
Yeah, thank you very much, Dan. And that's really important fact to know, that it's not addictive. And I know from the ground, as a lived experience ADHD myself, and the community that I'm part of, actually one of the very common things that we face is people forgetting to take the medication. So, we actually have to put alarms to remind us. And I've been guilty of it myself. And I take the meds, I say, oops, did I take it or did I not take it? That kind of thing. So I think that's one of the anecdotal, on the ground thing about not being addictive.
If taken as prescribed. Okay, we always need to qualify.
That's a very good qualification.
Yeah,
yes. The other misconception that comes up quite often is that, my child took ADHD medication and he turned to a zombie. I don't recognize my child. So I don't want my kid, to be like dulled, in terms of the behavior and everything to that extent until they're no longer themselves. I was wondering, Adrian, do you have any comments on that one?
Yeah, I think for ADHD medications, by far and large, they don't typically cause the kind of zombies of presentation which some parents may have from online. online forums or perhaps from other parents, it could be confused perhaps with other medications which may be used. But for ADHD medicines, by far and large, they don't cause the kind of effect. And that's the other thing I always reassure the parents who
Adrian, you're breaking up a
to
little bit, so maybe just check on the sound, right?
yeah. The other thing I usually tell the parents is that for the medications, usually if there are any side effects, they're all short term. So it's always worth a trial because we know the benefits far outweigh the issues that may be with the ADHD medications. So once you try to have a trial and if there are really any unpleasant side effects by stopping the medications, then the issue is settled. It's something that's going to persist for forever.
Understand. Thank you. Dan, anything to add to that?
Yeah, social withdrawal, cognitive dulling are possible side effects of these medications, but I agree with Adrian, they're avoidable. So on the list of possible side effects, if you go to my website and go to that stimulant trial sheet, you will see, not the word zombie, but social withdrawal, dulling can happen, but that's a dose-related potential side effect that we don't allow to continue. If parents saw that kind of effect on personality, the loss of sparkle, having a child lose their sparkle because of treatment with ADHD medicines is a crime. We don't want to treat ADHD and have kids lose their sparkle. The good news is if that happens, we would see it at a low dose, just a little, and we don't increase the dose then. We don't let side effects happen. That's a myth that side effects must happen if you're treating ADHD. The whole goal of treatment that I want to emphasize is we're going to be carefully adjusting the dose of medicine to maximize the benefit, minimize the side effect, and loss of sparkle, cognitive dulling, is a dose-related side effect. We can tune down the dose or change medicine and avoid it. Careful monitoring, careful education is the key to minimizing any side effect.
Yeah, thank you, Dan, for that. That's a pretty important message that I want people to be aware of as well, right? Is basically get back to your doctor, talk about what's happening, what you're observing, and then see how you can modify the dose. Don't give up. Because I think myself as a parent, when I first put my own daughter on ADHD medication, one of the things that I wish I was informed, and now we're trying to make sure people know about it, is that ADHD medication doesn't function like a painkiller or an antibiotic, that once you take it, wow, immediately a miracle happens, and you've got immediate results. What I learned the hard way was that it actually is a process of adjustment, calibration, working closely with your doctor, your pediatrician. So basically it's not to give up when at first it's maybe not having that effect that you're looking for. And that's why I love your medication trial, Dan, because it's a very systematic way of approaching it. So people know that they shouldn't give up too early, until they've tried everything.
Super important point, Moon. Yes. And I didn't emphasize this enough when I presented my trial sheet. We do want to actively involve teachers. And if there's another important person in your child's life that you trust, a coach, a tutor, anybody who knows the child well, in an ideal world, we get input from the parents, from the child, and from at least one other adult, usually a teacher. And I ask people to fill out my form, scan it, or take a picture of it and send it to me once a week. And then I put together that data, get back to parents on a weekly basis, and we make adjustments. Your point, Moon, is we keep working at it, tuning. This is a little bit of a trial and error process over time. And it changes over the years as kids go through different developmental phases. But just like anything else, like diabetes, like allergy, we make adjustments. That's what we do, and when we're doctoring, right?
Yeah, and what I like about the medication trial is that the keyword is trial. So if people try it, for a period of time and it doesn't work, that's fine. Let's give it a shot, right? Because we've noticed as well, a lot of people put medication as the last resort. And usually that's when everything else has been exhausted. And then there are, of course, other issues to do with that. One question that's come in the question and answer, and that's also come in the pre-submission for the event, is there was some concerns here from parents about children taking it when they're very young. So two aspects to this question. Number one is how young is too young? And second aspect of this is, will it stunt growth, especially when kids are going through that puberty phase?
Dr. Lowe, do you want to take that one?
Yeah, so I think in general, when they present at a very young age in preschool, they can actually be given stimulants, given ADHD medications, if we actually are sure that the diagnosis is very clear. So what we need to really make sure is the diagnosis is absolutely clear. And for that, of course, that can be quite tricky because when they're younger, there are just so many differentials to consider. But if we are very certain there's an ADHD and it's really causing a lot of disruption, and then actually it is worth a medication trial. So I think even at the preschool age, it is still possible. Although, of course, in clinical practice, many parents will be very reserved, will have a lot of, they would generally have a very cautious approach. So sometimes pragmatically, they may hold off the decision until somewhere around the elementary school or primary school age. Yeah, so that's what we practice locally. And then as for the concerns about growth, the studies that touch about growth, they actually really involve large populations, and when they actually talk about the actual growth differences between two cohorts, where one was on ADHD medication and the other wasn't, the actual difference in the mean height was actually really quite negligible. It's about in the order of 1 centimeter. So what we practically do is we actually monitor the growth of children, especially when they're particularly young. And then we also, just like any other child, we use their development booklet to chart their growth and to make sure that it's following the charts. But in clinical practice, I've actually never encountered somebody who went off the chart because of being on ADHD medications. But I do understand that will be something that comes up as a concern. So I think we should monitor it, especially when they are very young.
Yeah, I agree with all of that. And you know, I have seen some growth deceleration, generally secondary to significant appetite suppression. But we pick up on that and we don't let the medicine continue at a dose that is interfering with calorie consumption. There are adjustments that are made, and we'll talk about managing side effects in more detail next week. The more severe the impairment, the more severe the ADHD, the earlier we can make a clear diagnosis. So the kids with severe impulsivity, hyperactivity, distractibility, they're being kicked out of their third preschool. There's a more compelling reason to go ahead and treat with medication. Children with milder ADHD tend to be diagnosed later, and we tend to go with non-pharmacologic management first. So with any disorder, the more severe, the more clear the diagnosis, and the more incentive there is to treat at a young age. The older I get, the earlier I treat. I've learned over my career, if you let ADHD go untreated, even at a young age, especially at a young age, personality development is affected. You have a can't-do kid instead of a can-do kid. You have a kid with a negative self-image instead of positive self-image. You have a kid who's been getting negative feedback, redirection through early developmental years, rather than a child who is experiencing joy and pleasure and success in social communication and social connection. So the stakes are high. If you have a child with severe impairment from ADHD, you don't want to delay intervention. To agree, Moon Lake's, you don't want to save it for a last resort. It should be upfront, the most effective intervention that we have for ADHD.
Thank you. That's such an important point to know. And sort of going from that question, right, or that answer, one of the questions that we received, right, was, oh, I've been recently diagnosed with high functioning ADHD. Okay, or someone maybe has a milder case of ADHD, probably doing well in school or well at work. And so the question was, should I be on medication if I've been surviving all these years without medication? And how will medication help me? Maybe Adrian?
Well, so yeah, I guess it depends also on the age of the person asking. If they are functioning quite well, I suppose the question I would like to ask is, which areas are they functioning very well in, and are there still other areas of their life which perhaps they may not be functioning so well? So I have come across people who still actually do pretty well scholastically in the studies and all that, but the difficulties they're having in ADHD, as what Dr. Dan mentioned earlier, actually shows up a lot in the executive function area. So they have difficulties with organizing a lot of their schedules. They can't follow through on certain plans. Yeah, they can be quite forgetful, and because of that, cause a lot of disruptions at home and all that. So they may still be able to, because of the high intelligence, typically, they still get through with the academic side, but they may face a lot of difficulties in other areas. So I guess, given a chance, I'd like to clarify really what is the exact nature of the functioning in the different domains of life, academic, social, emotional, and then from there, take it from there. Yeah.
Thank you. That's such an important point, because one of the things that we're seeing as well is that kids or even adults who are coming from so-called highly ranked schools who do well academically, or grown-ups who are, let's say, professionals. Some of them, when they go in for consultation with a psychiatrist or another mental health professional, they are told they can't have ADHD because they got a degree, or they did well in exams. And that
Yes.
seems to be some kind of correlation. But we do know that there's a category called the twice exceptionals, like the bell curve, that those that actually have a high IQ are gifted in some ways that also are struggling with executive function and ADHD. So it's important to look deeper, right? And as Dr. Shapiro said earlier, the executive functions, or dysfunction rather, might be one of the clues as well, among other things. Other question here is, does medication work differently in girls compared with boys? Specifically, I noticed that my daughter's symptoms get worse around the time of the month that she has a menstruation. So is there a connection, and should her medication be varied over time? Maybe Dr. Dan
Yeah,
first?
yeah, it's a fascinating question. Dr. Catherine Nadeau, spelled Nadeau, is actually a colleague of mine here in the greater Washington area. She and Dr. Quinn have written a book on ADHD in girls, and they make this point, that there can be variation in ADHD symptoms according to menstrual cycles. So she has taught me to ask about this. And there have been a few cases in my career where it seemed that fluctuations in hormone levels, in mood, had an impact on ADHD. And she suggests sometimes adjusting the dose of ADHD medicine accordingly. In my own experience, since she sensitized me to this and I ask about it, I have not seen it in real life being a factor. It's the exception rather than the rule. And I suspect it's not fluctuations in ADHD that causes variations in day-to-day functioning. It's mood, some premenstrual symptoms of depression, anxiety. And there, rather than adjusting ADHD medicines, if it's severe, we're talking more about SSRI, selective serotonin reuptake inhibitors, for anxiety, depression. And Prozac or fluoxetine has actually been double marketed. The more traditional uses for depression and anxiety, but it's also a brand name here in the United States is marketed for premenstrual syndrome. So I suspect that's more where the action is than ADHD changing per se. But read Dr. Nadeau's stuff on that if you want a deeper dive.
I would love to meet her, actually. And I know that she's also doing research on ADHD in older people. So
yes, that's right. Yeah.
Yes, so I definitely am interested, to connect. So going back to this, and I'm glad you brought up things like anxiety and depression, because we do know that those are a very common comorbidity, ADHD and anxiety, depression, and some of the other conditions. So how does one figure out, how do you manage the medication for these kind of mood disorders? And when does one figure out, is it ADHD or is it anxiety? Or is it ADHD or is it depression or both? Maybe Dr. Loh, you might want to start first, and then maybe Dr. Shapiro.
Yeah, so I think if I refer to Dr. Dan's earlier presentation, that sometimes it may be both. So definitely we don't want to rule out either one early on, but really just to take a thorough history. Usually for clinical work, it really starts from getting a really thorough history. When did the symptoms first present? And so we go back in time because typically for ADHD, the symptoms should present at an earlier age. And of course, from anxiety disorders, they typically also do present in the elementary school age. But for mood symptoms tend to come out a bit later. So getting a bit of an understanding of all the timing of all the different symptom onset can provide us a clue. Now, if we do really make a diagnosis of both conditions, both ADHD as well as either a mood or anxiety disorder, we do want to have an understanding of the severity of the mood and anxiety disorder. So one of the things to really emphasize is that for ADHD, medication use is actually really should be a first line option. Whereas for mood and anxiety disorders, medicines play an important role, but oftentimes we may want to consider other psychological therapies, counseling, other kind of social interventions before we actually start medication. So we really have to kind of like look at each person's story and try to figure out like where the predominant symptoms are. But if it's really clear as ADHD plus, then I'll really say that it's really worth, again, coming back to the whole concept of the medication trial to look at the use of ADHD medications. I also wanted to highlight that when there's a presence of coexisting conditions such as ADHD as well as another condition, sometimes that can influence what sort of medications may be best suitable. So if, let's say, for example, there's less severe insomnia, there are certain medications such as guanfacine, not so commonly used, but it is possible to use that because it is more sedating. And if there's a significant mood component, then propion, otherwise known as Wellbutrin in Singapore, can also be a useful option to treat both the ADHD and the mood condition. Having said that, it also depends on the age of presentation. So some of these medications, they may not be actually approved for use at different age groups. So we really need to have a bit more information on the person's, the specifics of each person's presentation.
Thank you. Thank you for very
Great
answer.
points, Dr. Lowe. I find myself agreeing across the globe with you on these important points. This is such an important question. I'm going to spend a couple minutes, Moon, if that's okay,
Sure,
just
please
expanding on what Dr. Lowe has presented. It is, again, the rule rather than the exception that ADHD travels with other conditions, especially anxiety and depression. And Dr. Barkley lobbied to have mood dysregulation as part of the diagnostic criteria for ADHD because the emotional impulsivity, the mood dysregulation that is so commonly part of ADHD often goes underappreciated. To that point, when you've got coexisting ADHD and anxiety, often you treat the ADHD and the anxiety comes down. Sometimes magically, not always, but sometimes. So when in doubt, treat the ADHD first. Now, if I ask a parent, hey, if you had two magic wands, only one magic wand, if you had only one magic wand and could only use it over the ADHD or the anxiety, which would you choose? If a parent immediately says, oh, the anxiety has always been the bigger issue and the ADHD seems secondary, sometimes we will treat the anxiety first. But when parents say, hey, I'd really need two magic wands, I've got significant issues with my child with ADHD and anxiety, treat the ADHD first. So now sometimes you treat the ADHD with stimulant medication or non-stimulant medication. ADHD medication you can think of as putting on the brakes. Stop and think medicine. Don't live so much in the moment. Consider past experience and future consequence. And what is a very, very common side effect of ADHD medicine? Putting on the brakes too much, actually amplifying tendencies towards anxiety and depression. That's not okay. You have to back off. So sometimes when you have coexisting mood problems, anxiety or depression, you're more sensitive to the mood side effects of ADHD medicine. Watch out. So sometimes you settle for partial treatment rather than amplify anxiety or depression. What is the number one side effect of selective serotonin reuptake inhibitors like Prozac, medicines for anxiety and depression? Well, these are medicines where you take your foot off the brake. Hey, don't stop and think so much. Don't live in the past and the future so much. Live in the moment. Be a little more ADHD. Let it go. And that side effect of taking the brake off too much with treatment of anxiety or depression can mimic ADHD, can amplify tendencies towards ADHD. So watch out. Don't overtreat your anxiety or depression because you might amplify the coexisting ADHD. Don't overtreat the ADHD because you might amplify the anxiety or depression. Do this. Just take the edge off the ADHD, take the edge off the anxiety and depression, and strike that balance between overtreatment or undertreatment of either tendency. Here's where recognizing it's an and, not an or, there are coexisting conditions in dynamic interplay is a key to effective management. So forgive the longer answer on that, but it's so common. And it takes an experienced prescriber to get this balance just right.
Absolutely, and I so appreciate it, Ben. I really do. Actually, we're running out of time. It's like, boy, time flies when you're having fun, right? But I want to make sure that I address some of the other common questions first, right? Before I let you guys go. So just going on from that about the comorbidity, because Unlocking ADHD and Spark, another charity in Singapore that supports parents with ADHD, we did a survey 2 years ago, and we had almost 600 people respond. Okay, and when we asked them the question, about 88% of the adults, answered that they had one or more other coexisting condition, and anxiety and depression were definitely up there. And same thing for the parents when they answer on behalf of the children. So this is something that I hope that clinicians and all those in positions that can do something about it, pay attention to. When there's someone that's having anxiety and depression and nothing is moving, even with CBT and other medications, perhaps explore as well whether there's something else that's underlying. I would like to move to another very common coexisting condition, and that's ASD, autism spectrum disorder. And we know that for ASD, the difficulty is not exactly one of those where you can prescribe medication, at least from what I understand. It's more of the therapy. So I'm curious, Dr. Dan, like for someone, and it's common too for people with ADHD, to 30 to 50% plus of them, have both ADHD and ASD. So how do you manage it?
Yeah, actually higher. There is no medication for the core symptoms of autism. There's no medication for the social disability. That's a core part of autism. There's no medication for the repetitive ritualized patterns of behavior, which is the other major diagnostic category for autism. We have no medication for those core features of autism. But as you're appropriately emphasizing, Moon, autism usually travels with ADHD, anxiety, often depression, extreme irritability. For these coexisting conditions, we do have effective medication. For the ADHD, the management is the same, although people with autism are more sensitive to side effects than people without autism. We still carefully go after the coexisting ADHD, anxiety, depression, extreme irritability. For these coexisting conditions, which are often the autistic person's primary source of impairment, we often do treat carefully, but with good success in most cases.
Thank you for that. Because we are seeing increasingly again more people coming to us with both conditions. The other question I have, in the interest of time, and I want to make sure that we give value to people, but also the practical stuff, right? Is what about those who, for one reason or another, are not able to access medication, either because they're waiting to get their diagnosis, or they haven't been able to get a diagnosis either for themselves or the child, or there may be some other reasons why they're not able to take medication for ADHD. Could you maybe share what are some of the ways that they can manage life without medication?
Dr. Low, I'll let you take that one from a Singapore context, please.
Yeah, so I think the Singapore context, sometimes there may be a bit of a wait time until in the public healthcare system, it could take about up to 6 months before they could get a visit to see a child psychiatrist. So of course, that's a long wait for any child or parent if there are clinical issues that they're facing. So some of the strategies that can be adopted while they're waiting to see the child psychiatrist, I suppose, is to continue the use of supplementation. Although of course, as compared to ADHD medications such as stimulants, the benefits of such products such as fish oil supplements or omega-3 supplements is comparatively on the low side. Having said that, it is considered to be still equivocally positive. So that can be something that can certainly be started, especially if your child is someone who's quite picky eater, and perhaps because of that has very little dietary intake of omega-3 oils to begin with, then that could be. I have had positive reports from some parents who do tell me anecdotally that they do feel that it has made a difference. So it's always hard to say placebo, but the research does show that it is actually beneficial. And I guess other than that, if there are any for example, there could be some conditions which the general practitioner referring can help with first. For example, there may be sleep issues and all that. Melatonin can be used in the interim while waiting to see the child psychiatrist to start a stimulant. Because we do know that if there's sleep issues, especially if there's the anxiety component, then that sleep issue itself could be heightening the attention issues in the daytime. I think we should work closely with the teachers where possible. So once the parent has had an appointment waiting to see a child psychiatrist, I think it's actually possible for them to highlight this to the teachers so that the teachers can, at least I think they know that the parents are, in a sense, partnering the school to be able to help the young person, and they will understand that there are difficulties too in the waiting and all that too, in the waiting time and all that. Yeah. So that's some of my perspectives on this.
Yes, thank you, Adrian. I know we're coming close to 9 p.m. already. I don't want to hold people, too late. So I want to respect Dan's time. Dan's about to start his workday. We need to give him some time in between. So we'll give you 1 or 2 more bonus questions, and we'll try to finish by 9:05. But in the meantime, I've shared the post-event survey. Please, do answer it, but we can still, chat with the doctors in the meantime, as the survey is being answered. Dan, on a practical level, because, what are some foods that one should avoid, when taking ADHD medication, or what are some foods that one should have in order to also address some of the other issues about ADHD medication?
As a general pediatrician, I would say that, for all children, we want a balanced diet. But there's no food supplementation or restriction that, based on the science, has a significant impact on ADHD. So good nutrition is good for all children. And so don't look for supplements or dietary restrictions based on the science to have an impact on ADHD.
Thank you. Adrian, anything else to add for that one?
Likewise, I would say that a balanced diet. And earlier on, I made a comment about picky eaters. So of course, we do know that for those especially with ADHD who may be presenting together with perhaps like autistic symptoms and all that, there may be also food sensitivity, sensory issues. So that's all present in the picture. That does complicate the matters on the diet, on having a balanced diet. I really have young people who have all kinds of strange diets that I can imagine is very nutritionally unbalanced. So I guess in those instances, not routinely, but for people who are really having food issues and all that, I think in recent times there's been a lot more awareness of RFID, avoidant restricted food intake disorder, which also travels along with all these neurodiverse individuals. That may actually be worth considering a referral to a dietitian, because I think the dietitian can actually come in and evaluate what kind of micronutrients may be missing, is there sufficient omega-3 fatty acids, and I think with that will be able to help the parents to establish what sort of supplementation is really scientifically called for that child. But this will be probably an exception. I think for most children, I think they probably do eat a wide enough variety of food to be able to so that they don't have any nutrient deficits. Yeah.
Thank you.
And in terms
of
more
practical, sorry,
Yep.
is that some people said you can't mix ADHD medication with things like orange juice.
Well, citrus, in particular, grapefruit juice has an enzyme that can affect the metabolism of many psychiatric medications, but I don't know any kids who like grapefruit juice anyhow.
What about orange juice? Orange juice? No?
Orange juice is no
To
problem.
eat oranges, okay? When I take my nap.
Orange juice is no problem. The grapefruit juice is unique. Yeah, in terms of non-pharmacologic management, we should not go on wild goose chases about food. Non-pharmacologic management is about behavior management. See my course if you're interested. About educational care, and about parent and child education, destigmatizing understanding ADHD. Those 3 non-pharmacologic interventions matter. And
Yeah.
even though we're emphasizing in this course the central importance of medication, again, medication is never the whole answer. It should be combined with a comprehensive care plan, including psychosocial interventions, educational care, behavior management. But let's beware everything that's on the internet that's not evidence-based. So I'll leave with that generalization that we want to follow the science, not the internet.
Understand. Okay, we're going to close this soon. So one last question for each of you. If people were to take away one thing, about ADHD medication, right? What should they remember or what should they know? I'll ask Dr. Low first and then I'll ask Dan after that.
Okay, I guess the parting word I'll give as being a psychiatrist is that ADHD medications actually have the highest, it's considered to be the most effective medications for any psychiatric condition for something that's a long-term for long-term purposes as compared to any other medication class in psychiatry. So I would really want to stress the importance of really considering a medication treatment trial as long as we can diagnose the condition very accurately, and not to let fear stop like any intervention until years later, but really just to have that conversation with the general practitioner, with the psychiatrist on the merits of starting medication.
Yes, thank
I
you. What
agree
about you, Dr.
100%. Yeah. And 50% of children respond to the first medication tried. Not bad, but that leaves 50% who don't, either because it didn't work or more commonly because you get into some side effects that limit the ability to continue with one medicine. If, to Moon Lake's point earlier, we have patience and we're deliberate in our commitment to getting it right, we hang in there, stay the course, go through the algorithm, try different things, that's when we get up to 80 to 90%, to Dr. Lowe's point, success rates. So my message is treat it because it's a serious condition that affects your child's life, and don't look for a magic bullet. Hang in there, stay with it, and you'll be glad you did for your child's development over the course of the rest of their life.
Thank you. So well said, Dr. Dan. Thank you for that. So, that wraps up tonight's, webinar. Dan, you've been amazing. Thank you, Dr. Adrian Low, also very amazing. Thank you for such practical and comprehensive answers. Again, we probably need a couple of episodes of this. And again, I would like to appeal again to those who are here. Please do consider supporting Unlocking ADHD, because again, we're only 2 years old. We are currently not getting any government funding. We are really very much, funded from donations, some smaller grants here and there. So if you really want to keep us going and our team going so that we can do more of these life transforming events for you, please make a donation. Again, it's eligible for tote board matching. Invite us, to your companies to give talks, help fundraise for us, having your own projects, because we really want to do more of these events for you out there. I think there's just so much more to unpack. So thank you very much, everyone. Have a good evening, and Dan, have a good morning. Really appreciate this, and let's see you next week, and then we'll continue the conversations. Thank you very much, everyone, and I hope you found this useful.
Thank you.
Okay. Good night, everyone.
Good night. Good night. Good night.
Take care.
Bye.
Bye-bye.
Thank you. Bye.